Hello, my name is Nikos Karavidas and I'm a physiotherapist from Greece. I'm going to speak about the physiotherapeutic specific exercises for Scheuermann Kyphosis. First of all, we need to make a differential diagnosis between postural or functional and Scheuermann Kyphosis. And for this purpose, we have the clinical and the radiological criteria. In the clinical evaluation, in both cases, we have poor posture and shoulders internal rotation and quite often a forward head position. The main difference in the clinical evaluation is that for functional kyphosis, we have a good flexibility compared to the spine rigidity that we see in Scheuermann Kyphosis. And in the forward bending test, in functional kyphosis, we don't see an angular kyphotic hump like in a Scheuermann Kyphosis, as in the example that you can see in the photo just in the middle. The most important radiological criteria for Scheuermann Kyphosis is the vertebra wedging. So what happens in a Scheuermann kyphotic patient is that for some reason we have an asymmetrical growth, having the dorsal part of the vertebra to grow higher than the ventral part, and we have this wedge shape. In order to say that we fulfill the radiological criteria for Scheuermann Kyphosis, we need to have at least 3 consecutive vertebra wedging, having a wedging of at least 5 degrees. Another radiological sign for Scheuermann Kyphosis is the increase of the anterior posterior diameter of the vertebra. Also some end plates irregularities, smear loads can be seen sometimes, and there is also a narrowing of the intervertebral spaces. However, there are some cases that are very typical functional kyphosis, meaning that they don't fulfill any criteria, neither clinical nor radiological. But we also have a typical Scheuermann Kyphosis patient that they fulfill all the criteria, both radiological and clinical. But there is also another category, we call it atypical Scheuermann Kyphosis, when we have some criteria but not all of them. So for example, we might have vertebra wedging in 1 or 2 vertebrae but not in 3, or we might have spine rigidity but not angular hump. Now let's take a look on the international guidelines from the scientific societies like the SOSOT for Scheuermann Kyphosis treatment. It is really important to differentiate between Scheuermann and functional, and the main difference for the treatment protocol is that for Scheuermann Kyphosis we will need to have treatment with brace and exercises, and the role of the brace for Scheuermann Kyphosis during growth is to change the growth velocity on the ventral part so that we have an equal growth in both parts during growth. Exercises are recommended before brace fitting, and this happens because most of the Scheuermann Kyphosis patients, they have spine rigidity. So if the brace is put on the patient with not good flexibility, then the correctability of the brace is reduced. So it is really important to combine brace and exercises when the patient is at growth. The exercises should be based on autocorrection, self-elongation, and activities of daily living training. And the general or back school strengthening exercises are not recommended for Scheuermann Kyphosis treatment because they don't have all these corrections that are required to get a good result. Sports are allowed, but they are not considered to be an alternative treatment option. And of course, one of the main prognostic factors is the compliance with the treatment protocol with brace and exercises. Unfortunately, in Scheuermann Kyphosis, we don't have too many research to prove the effectiveness of physiotherapeutic specific exercises. So there is a lot of work to be done in the future because we have just a few studies. One of them is very shortly presented here. is the effect of Schroth therapy on thoracic curve and quality of life in Scheuermann Kyphosis patient, and this is a randomized controlled trial. So the authors, they used two groups. One group did specific Schroth treatment, and the other group just classic anti-gravitation exercises, and they found that the results were significantly better for the Schroth group. There are several schools that are recognized by the SOSORT Scientific Society as Scoliosis specific or Kyphosis specific exercises, and here you have some examples. We have the SIAS method from Italy, Lyon from France, Schroth from Germany, Barcelona Scoliosis Physical Therapy School, Rigo Concept from Spain. This is the part that we're going to speak a little bit later. Dobomed and Fitz from Poland, and Sideshift from United Kingdom. So all of them, they should be based on self-correction, education of the patient, stabilization in correction, and activities of daily living training. It is true that we don't know the exact cause of Scheuermann Kyphosis, but we know how it is going to be progressed during growth. So what we have is that we have an asymmetrical loading of the spine, and then asymmetrical growth, vertebra wedging, and bigger kyphosis, and so on. So we have a vicious cycle that we need to break. So we need to reduce the asymmetrical loading, and this is why during exercises, as you will see later, we need to correct. First of all, put everything in correction and then activate in the corrected position. So to reduce the asymmetrical loading and asymmetrical growth and vertebra wedging, and to improve kyphosis during growth. The school that we are going to speak is the Barcelona Scoliosis Physical Therapy School, Rigo Concept. Is a program of physiotherapeutic specific exercises and belongs into a comprehensive scoliosis care model and kyphosis as well. And the general and specific principle of corrections for this school are based on the original Schroth method, and further developed by Dr. Manuel Rigo based on clinical experience and external evidence. In order to understand how we apply the BSPTS-Rigo concept, we need to answer three questions. So the first is for what we do, and we have the general or main objective. What we do are the general principles of our school, and how we do is the general principle of correction and specific principle of correction. So the general or main objective of our school is to learn an efficient self-correction, to get the best possible 3D trunk and spinal alignment, having no compensations, bringing the spine and the trunk in harmony and balance. These are the general principles of our school. We have the stable 3D postural correction, expansion technique, muscle activation, and integration. So just to give you a better explanation on this, what we need to do in order to treat kyphosis is to, first of all, bring everything into correction. So we need to correct the posture and also bring not only in the sagittal plane but in all three dimensions in the best possible alignment. Then we need the expansion technique is connected with the breathing. So we need to open the collapsed areas, and what we need more in typical Scheuermann Kyphosis patient is, of course, the axial expansion, which goes together with the elongation. So we need always to keep the patient in a good elongation. And in Scheuermann Kyphosis patient, what happens is that the sagittal diameter of the thorax is increased due to the kyphosis, and the transversal diameter is decreased. So we need to work a little bit more on the axial and transversal expansion. And then, of course, we need to activate in correction. This is the part of muscle activation, and all these three general principles work together from the very beginning of the application of the technique. And of course, when we finish the exercise, there is the integration, so the last general principle of our school, and it is really important because we need to transfer the correction into the activities of daily living. So to keep the correction after the exercise and implement during daily life. The general principle of correction for our school is the best possible sagittal alignment and balance, because we speak for Scheuermann Kyphosis, which is a one-dimension deformity. And then we have the specific principle of correction. The first is self-elongation from a 3D corrected and stable pelvis. This means that we start the corrections from down to up. We need to have a stable basis, so to correct pelvis and then apply the corrections in the trunk. Then we have the symmetrical sagittal straightening or alignment, and of course frontal plane alignment should also be there. And lastly, we have the predefined strategies of correction, including pelvic corrections and a specific technique. We name it shoulder traction technique for our school. So here you can see a typical representation of a thoracic Scheuermann kyphosis when we have the body divided into blocks. It comes from the original Schroth method. So we have the thoracic block that is shifted backward, and shoulder block is shifted forward, and the lumbopelvic block is also shifted forward. This situation is not really frequent because, especially in young adolescents, but we can also see sometimes thoracolumbar kyphosis. This means that the kyphotic region comes down to the thoracolumbar area, and then we have this representation having a main thoracic block being hypokyphotic, and lower cervical part being kyphotic, upper cervical part being lordotic, and of course there is a lumbopelvic lordosis to compensate. So as you see in this example, for the symmetrical sagittal straightening and the self-elongation, the specific principles of correction, they work perfectly together, because the self-elongation means that we have a cranial and caudal force to bring the body into correction, and these of course give symmetrical sagittal alignment. And on the other hand, symmetric sagittal alignment, so moving the thoracic block forward, the shoulder block backward, and the lumbopelvic backward at the same time, gives self-elongation. So these two specific principles of correction, they work perfectly together. This slide is already described, and this is about the self-elongation to correct. Here I'm going to speak a little bit more about the importance of the pelvic correction. So we have the second pelvis correction, which is to bring the pelvis into a neutral sagittal position, playing with anteversion and retroversion, and keep it stable during exercise. So the concept is that in order to get the best possible self-elongation, you need to have the pelvis in a neutral position. If you have the pelvis in more anteversion, this, or more retroversion, this will reduce the chance for the best self-elongation. Here you can see some examples of exercises from our school. We have the semi-hanging exercises, or semi-hanging on the ball. We usually do a lot of exercises in a hanging position because this gives us a very good sagittal alignment. These are two other exercises, prone on stool and prone on knees exercise. And for the last part of the presentation, we're going to see some examples of patients that were treated in our clinic. So here you can see an atypical Scheuermann Kyphosis patient treated only with exercises. In this case, we had kyphotic angle of 52 degrees, and we have a spine rigidity and also vertebra wedging, but we didn't have an angular hump. So this patient decided to be treated only with exercises, having a very nice correction, being at the end of treatment in 38 degrees, and with a significant clinical improvement as well. This is another example with a functional kyphosis, no Scheuermann findings, no angular hump, but this patient was prescribed by a doctor to have a brace. So we decided not to use a brace because this was a functional kyphosis, and you can see the amount of correction that we achieved to get with only exercises, reducing kyphosis from 54 to 32 degrees. Of course, Scheuermann kyphosis can be effectively treated also in adults. So here you have an adult lady of 37 years old with B kyphosis 67 degrees, an angular hump, spine rigidity, suffering from pain with a certain wedging of the vertebra, and you can see the amazing result that we got in this patient, reducing her kyphosis from 67 to 41 degrees, having a significant clinical improvement. Also, pain was eliminated. And thank you for your attention.